Hello, it's Grand Rounds time, and I'm going to introduce Dr. Aaron Lyon, who's an acting assistant professor in our department. His research focuses on increasing the accessibility and effectiveness of psychosocial interventions for children, adolescents, and families, delivered within contexts that routinely provide care to chronically underserved populations. Dr. Lyon's recent projects have focused on promoting mental health practitioner behavior change and the uptake of evidence-based practices by clinicians working in schools and community mental health settings. He is particularly interested in the identification and implementation of low-cost, high-yield practices, such as the use of standardized assessment tools for outcome monitoring, to reduce the gap between typical and optimal practice in low-resource contexts, and methods of promoting flexible and effective implementation of evidence-based psychosocial interventions for youth and families. Dr. Lyon is a co-investigator on a grant funded by the Institute of Educational Sciences to develop a brief, modular psychosocial intervention for youth experiencing a range of mental health problems in schools, and he's principal investigator on an NIMH Career Development Award to study the adaptation and implementation of a computerized system for clinical progress monitoring with school-based clinicians. He's also the 2012 recipient of the Pearson Early Career Grant awarded by the American Psychological Foundation to explore methods of maximizing intervention setting fit in school mental health. Dr. Lyon.
Thank you. It's Grand Rounds time. So thanks for having me. I'm pretty excited to be here today and to be able to talk about some of the work that I'm doing and also framing it in the context of some kind of exciting work and study I've been doing in the field of design and user-centered design, which I'm going to get into in just a moment. First, I want to acknowledge a range of collaborators and funding sources. Obviously, none of us do our work in a bubble, and we couldn't do it without all of these people and sources of support. What I'm going to be talking about today is first the design of evidence-based treatments. And then I'm going to go on and talk a little bit more generally about evidence-based practice and the implementation of evidence-based practice in schools. And then I want to tell you about a couple of current research directions I'm engaged in within the Seattle Public Schools and within King County. So I want to start by telling you a tale of two gaps, and I don't think either of these is going to be particularly novel to anyone in this room. And these are two gaps that I'm focused on with a lot of my research. The first is the gap in evidence-based practice application. This is sort of the research to practice gap. This is where we have a wide variety of research-supported interventions that aren't necessarily being used frequently or well in community settings. And then the other is the gap in access and utilization of services. And I would say that these two gaps are very much interrelated and complementary. It doesn't matter how effective your intervention is if no one's using it, and it doesn't matter how accessible your services are if the care that's delivered isn't going to be of high quality. Focusing mostly on the research to practice gap is what I'm going to be about today. And I don't think it will probably strike anyone as a surprise that it can take 17 years for just 14% of original research to benefit actual care. And within the field of youth mental health, there's been some findings that have demonstrated that evidence-based practices are used frequently in usual care settings, and that when they are used, they're often used at concentrations or frequencies that are unlikely to result in an actual therapeutic benefit. This is also true in schools. School-based services are unlikely to be evidence-based and often demonstrate, there's actually a recent meta-analysis that's referenced in the last point here, low effectiveness and actually some iatrogenic effects or negative impacts for some school-based mental health programs. So we have a ways to go. I want to talk a little bit now about evidence-based practice and evidence-based treatments specifically. As defined by the American Psychological Association, evidence-based practice is the integration of the best available research with clinical expertise in the context of patient characteristics, culture, and preferences. And then more specifically, we have our evidence-based treatment protocols, and you can see a variety of evidence-based treatment protocols for youth mental health across the bottom there. Parent-child interaction therapy, the Incredible Years, the Coping Cat program. These all have a substantial body of evidence. And most of the empirical literature and the evidence we have for our interventions exists at that level. It exists at the level of the individual treatment protocol. And historically, these protocols have been the primary medium for the dissemination and implementation of effective practices. I want to pause for a moment and talk a little bit about engineering and design. As part of my Career Development Award, I've had the really great opportunity to be enrolled in a certificate program through the Department of Human-Centered Design and Engineering, and the program is in user-centered design. And we talk a lot about the difference between engineering and design. Engineering being more rule-bound and somewhat formulaic, and resulting kind of in these functional yet inelegant solutions that don't necessarily take into account human factors and human interaction. Design, on the other hand, may be somewhat more subjective, but focuses on producing products that really meet requirements well, or meet requirements in ways that are compelling to users. And in that way is very highly dependent on human processes and human interactions. And I just have kind of a couple examples up there. I would say that that car engine, is probably a marvel of engineering, whereas a lot of people would argue that the iPhone and its sort of simple and compelling and fairly intuitive interface is an example of good design. So in a way, engineering is really getting the job done, and design is getting the job done well. And I'm going to argue that our evidence-based treatment protocols are very well engineered. They produce their intended effect, usually through all means necessary, however many sessions we need or practices we need to bring to bear on a particular, pretty well-specified mental health problem. We're going to do it. We're going to get that into our evidence-based treatment protocol, our manualized intervention protocol. They generally present a universal and robust solution to what's typically a single problem. It might be major depressive disorder. And they emphasize, very much so, technical correctness through things like fidelity and a strong adherence, or at least goal of adhering with fidelity to the model. I'm also going to argue that our evidence-based treatment protocols are terribly designed. And to give you a little bit of a background more generally about what I mean by bad design, I want to show you a few things. This is actually from the cover of a book by Don Norman, who's a giant in the field of design. It's called The Design of Everyday Things, a classic book. And this is an unusable teapot that has a lot of the components of a usable teapot, but as you can see clearly, there's no way to pour it. If it's actually hot, you could end up burning yourself reaching for the handle. This is an example of almost comically bad design. I don't know if this is from Seattle, but I think it could be. And this is another example of bad design, something that's not intuitive, especially if you're moving very quickly. I think that this has a lot of applications to our evidence-based treatment protocols. If you're moving quickly through your session and you're trying to figure out which way to go, they're often not that intuitive to use. You're not going to be able to glance at them and figure out exactly what you need to do. If you've ever seen anyone from out of town try to park in the city of Seattle, I think you've seen evidence of how badly designed our parking meters are. There's too many buttons, they're too confusing. This is really, I would say, an example of poor learnability and the absence of rapid learnability. We have...
I have to interrupt here. What if the goal is to get more parking tickets?
That's a good point, Doug. If the goal is to get more parking tickets and to actually decrease use of your innovation, then we're right on the mark. And I would argue that in addition to being difficult to learn, and difficult to learn quickly, that they're also not particularly durable. I snapped this picture myself just last week. I assure you I was not using this at 112 o'clock, and it did not cost me $112. But I think this is an example of how these might not be particularly durable or sufficiently durable for their context.
At least that one had a non-scratch screen and a light on. So you could actually
That's true. Well, there are scratches on the screen if you look very closely. And it was also, I think it took maybe a minute and a half of contacting my bank for approval. And I think that this is also true of a lot of our evidence-based treatment protocols. They're not particularly durable. If we have a non-compliant client, if we run into some hurdles along the way, we don't always have a good path to respond to that. On their own, these two urinals are perfectly appropriate and effective innovations. However, the fact that they've been arranged in this way makes it almost guaranteed that they're not going to be used simultaneously. And like a lot of our evidence-based treatment protocols where we end up combining one with another and moving toward greater complexity, there's a lot of situations where we're not creating something where both of these innovations are likely to be used simultaneously and effectively. Maybe alternating, maybe. So in general, I think that our evidence-based treatments suffer from feature creep. The misguided notion that somehow more is always better. More sessions, more components. We need to do more things. We need to address more within each particular session. And we don't necessarily know if this is the case and how much this is really helping. There have been some studies I'll talk about in a moment looking at this in a variety of fields. I'll just kind of give one example. But this is a pretty complicated pocket knife. It's not really even a pocket knife anymore. It's a backpack knife. And maybe, just maybe, the knife and the file are all we really need to deal with most of what we're going to encounter in our day-to-day lives. So I've already made a few of these points. Evidence-based treatments are, I would say, too long, often with diminishing returns over time with increasing dosage, are generally inflexible, or at least perceived to be inflexible. And even though I think that there's often more room within a particular evidence-based treatment protocol for flexibility, the fact that they're perceived frequently by community practitioners as being inflexible is also an indicator of poor design. They're complicated and difficult to learn. Extremely complicated and difficult to learn. One of the most robust findings in the implementation science field is how difficult it is to get people to change their behavior and pick up an evidence-based treatment protocol and use it with fidelity. You can't do it by just handing them the protocol. You can't do it by sitting down with them for a week, for 40 hours, and teaching them how to do it. You have to do more than that. I mean, and I think that that is in a lot of ways a function of their complicated design. And we don't even know which parts are really important. We're doing some unpacking studies to begin to look at that. But for the most part, it's a mystery. And then they're also, as I said, prone to increasing complexity, often without added benefit. This is just a quote from, actually, an article in a program of research I really enjoy and really respect, where they've previously paired motivation enhancement strategies with PCIT, parent-child interaction therapy, which is an evidence-based treatment protocol for disruptive behavior. And they found that that did add benefit. But here they have now motivation enhancement and PCIT interventions, and then they also added individualized enhanced services with particular attention to services targeting parental depression, current substance abuse, and family, marital, or domestic violence problems. And I think that this is really feature creep. And this actually didn't result in any added benefits. And in fact, there were some indicators that it may have lessened some of the benefit of the intervention. So why are evidence-based treatments badly designed? I would say in part it's because they violate a number of core design principles, one of them being learnability, and that when possible, to create something that's well designed, we should increase the ease or speed of learning and mastery. They often ignore functional minimalism, where too many features, functions, or components are going to reduce usability. Cognitive load, minimize the amount of thinking required to complete a task. We don't do this particularly well. And exploit natural constraints. And so often, especially when we're talking about transporting an evidence-based treatment from one context to another context, we're talking about overcoming natural constraints, contextual factors, situational factors, and trying to remain completely true to our original model, which may have been validated in a completely different context, instead of trying to embrace some of these natural constraints and see what we can do to make a better fit and more effective intervention in the new context. So you probably won't be surprised that I'm going to argue that design is a key implementation factor. Implementation, of course, being active and planned efforts to mainstream innovations in service organizations. We can really think about evidence-based treatments and evidence-based practices even more generally as products that are intended for users, products that are often not particularly well designed, and that problematic design inhibits uptake, inhibits sustained use by individuals or by service systems. So how can we design better for implementation? I think that there's a number of things we can do. The first is to consider your users. This is a wonderful mantra, a quote attributed to Don Norman, again, the author of the book with the teapot. And the quote is, "The user is not like me." And I think that that's something that we don't pay very good attention to when we're thinking about our dissemination and implementation efforts. The user of a manualized protocol is not a doctoral level, CBT-trained clinician. The user is a very different individual. And even though this is a mantra more for originally, let's say, for web designers and for engineers of that sort, I think it's something that we can learn a lot from and can really apply to our work. And we can do that in a number of ways. We can carefully evaluate the context of use and user experiences. Does anyone know what that is, the chair there? If you listen to NPR, you've probably heard it, the Herman Miller Aeron chair, right? Locally, I think it's usually part of the Sit for Less commercials. So clearly I listen to a lot of NPR. And this chair is actually one of the first chairs that has no cushions. It actually has more of a netting that contours to different body types. And it's designed to move in ways that people move in chairs anyway. And this is really the result of careful evaluation of the context of use and the needs of end users. Anyone know what that is in the middle? This is a $9 cardboard bike that can hold nearly 500 pounds and was recently released and got a lot of press back in September. I think it was September. And this bike has been talked about as a potential mechanism for kind of disseminating or implementing bike technology in rural Africa to help children get to school when they have to cross great distances. It's cheap, it's disposable, I think it's largely recyclable. And I think this is a really, really great example of how simplification can really enhance dissemination. And no one's going to go and win the Tour de France on this bike, probably. Not without the proper doping regimen. But this is a way to get a lot of effective ideas out there in a way that's going to have real impact and real widespread public health kind of impact. And how about the last one? Anyone know what that is? Exactly, the Dyson vacuum, which was the result of literally thousands of iterations. And one core principle of design and one core design method is iterate, iterate, iterate. And I'm going to talk a little bit about how we've been trying to do that in some of our projects. So now I want to go and apply some of this to school mental health and some of the work we've been doing in schools. And first I want to talk a little about why schools. Why am I so interested in schools? It was in my title, right? It was in my description of my background and my research interests. I think schools have a lot of value. When you think about how most youth require mental health services, who require mental health services don't receive them, it's about 80% of kids who would meet a diagnosis and would be able to receive indicated services don't receive them. And that these gaps disproportionately impact low SES and ethnic minority populations. But what we know is that schools provide service access for underserved youth and can really lessen that gap in service access. And that's what we found in some work we did looking at youth who had some symptoms of depression. We looked across specialty mental health, school-based services, and primary care services. And across different racial and ethnic groups, we found, as you can see pretty clearly, that although there are pretty substantial differences in specialty mental health service utilization, schools wind up being, in many ways, the great equalizer, or a great equalizer, or have that potential. It's not perfect, but have that potential. And that's one of the reasons that I've been so interested in trying to embed evidence-based practices in schools, because they're already offering this very high level of service access. So schools are really the de facto service setting for a lot of youth, providing over 70% of all mental health services. And this includes both prevention and intervention services. But that's a large chunk of care when you think about it for a particular population. There could be a lot of reasons for this. Some have suggested that it's due to decreased stigma for service seeking, but all of this works out to about 20% of all students receiving school-based mental health services annually. So it's not all rosy, though. There's a lot of room for improvement, particularly in the use of evidence-based practices, as I hinted at earlier. There have been few interventions that have been delivered in schools that have been actually designed for or tested in authentic education service delivery settings. So most evidence-based interventions that are used in schools were really developed elsewhere and transported into schools. And unfortunately, a lot of evidence-based practice developers haven't paid sufficient attention to the school context and how the natural constraints present in schools might be influencing service delivery and the usability of practices, I would add. Some of these natural constraints in school mental health, some that we've documented, include a diverse range of client problems. This is both a diverse range of types of problems, which I think you see in a lot of settings, and also a particularly diverse range of problem severity, in part because of service access. We have a large number of kids who would not meet criteria for any particular clinical diagnoses, but are nevertheless experiencing sufficient and impairing difficulties that need to be addressed. There's a great range in treatment engagement and treatment duration. This is for a lot of different reasons. Some kids come and go and sort of float in and out of school-based practitioners' caseloads, depending on how it's set up. Also, a lot of variation in duration. So some of these kids are going to come in and get a few sessions, and others are in practically for their entire middle school or high school career. There's a lot of unpredictability in this setting. I would argue in some ways more so than in a lot of other settings. There could be fire drills, there could be assemblies, and that's without even thinking about how student absences are often going to impact the delivery of school-based services. And all of this, I think, is influenced by the fact that receipt of care, receipt of mental health services, is not the primary reason the kids are there. And I think that that's an important natural constraint that as school-based mental health providers or school-based mental health researchers, we need to be thinking about. They're there to receive an education, to sort of get that socially desirable value of education and sort of freely available public education usually. And mental health services are often seen of as an adjunct or as something that is only as good as it can sort of be present to facilitate that larger goal, which is an important natural constraint, as you might imagine. So in Seattle, a lot of the work that I've been doing is in the system of school-based health centers. School-based health center is essentially an integrated care clinic situated in schools. There's over 2,000 of them in the country, and they typically provide both primary care and mental health services. Seattle school-based health centers are a result of a partnership between the Seattle Public Schools and the Department of Public Health of Seattle and King County, who have really been great partners throughout all of this. There's over 16 clinics in high schools and middle schools. Pretty much all high schools and over half the middle schools have school-based health centers. A lot of funding comes from the Families and Education Levy. And even though they're overseen by the Department of Public Health, they're actually staffed by specific sponsor organizations that are community-based service provider organizations. So I've been working on a couple of different projects that I'm going to talk about today that are focused primarily on the simplification of evidence-based practice and the iterative development of sort of methods of supporting or methods of using evidence-based practices in order to match user needs in the school-based mental health context. The first is development of a brief modularized intervention for school clinicians, and the second is the adaptation and implementation of a computerized client registry system for assessment, progress monitoring, and feedback in schools. So the first one, the brief intervention for school clinicians, or BRISC as we're calling it. This is supported by a grant we got from the Institute of Education Sciences. Elizabeth McCauley and Eric Bruns are the PIs on that. It's also supported by my Pearson Early Career Award from AAPF. And this, we're not the only research team to think about how we can take research evidence, the large body of research evidence, and distill it down and try to make good use of it. We have a whole bunch, and I already showed you some of the slides talking about this, of evidence-based treatment protocols. And we have, in fact, we have 435 trials with over 750 evidence-based or 750 protocols that have been tested, representing 44 years of research. 400 years of research? Not quite. 44 years of research. And you can see a number of them back there, some of them are the same ones I showed you earlier. We have a substantial body of research evidence that we know isn't being used particularly well, isn't being leveraged to get the majority of kids who are receiving services better. So there have been a lot of people talking about how to make use of this research information. And one of the pioneers of this has been Bruce Torpeda and his work with John Weiss and Eric DeLeyden. And they've developed a distillation and matching model. And what this says is that evidence-based treatments can be distilled into common practice elements or modules and then matched to client characteristics. This distillation process really involves seeing evidence-based treatments as sort of collections of strategies, of treatment strategies, and going through this distillation process involves identifying those techniques across different evidence-based protocols and then accumulating evidence across these different research studies at the level not of the evidence-based treatment protocol, but of the individual practice element. And then going through a process of matching those treatment elements to various considerations in the clinical context, the most important ones being their association with the characteristics of potential service recipients. So identifying things like exposure is a great example of a treatment element, of a technique, and then looking at how frequently that occurred in evidence-based treatment protocols that were found to be better than their comparison group. And then saying, okay, and now if we break those down by different presenting problems or subject age and subject gender, then we can begin to match these to presenting to actual cases that and determine the extent to which they may be relevant and we should consider using them. I want to just make a distinction between common elements, which is a lot of what I'm talking about, and common factors. Common elements are these generic components or procedures of treatment, things like exposure, things like psychoeducation, things like teaching parents how to praise their kids that cut across distinct treatment protocols. And those I'm distinguishing from common factors. Common factors being sort of the more classic personal and interpersonal components like therapeutic alliance and things like that are common to all interventions and responsible to some extent for treatment outcomes. The approach I would take is that common factors are necessary but not sufficient to produce the kinds of outcomes we're looking for, and that common elements can help us to fill in additional gaps and figure out what we actually need to do in session. This is a great example. This is the Managing and Adapting Practice system, which was put together by Bruce Torpeda. And this is a wonderful example of how we can improve the design of evidence-based service delivery. There's three major components to this. The first being, on the left, the PracticeWise website, which provides essentially a living, breathing meta-analysis where they're constantly coding studies, including RCTs, and looking at and frequently updating their list essentially and their database that can produce particular practice elements that match whatever client presentation you might enter. And you can enter things like presenting problem, of course, age range, gender, ethnicity, and even service setting. And of course, the more parameters you put on it, the more limited it becomes. But what happens when you put that in is that you get these practice elements, and there's an example, self-monitoring being one of them, which are short, two-page overviews of how to use a particular practice. And then finally, and perhaps most importantly, there's the clinical dashboard that involves the tracking of both. At the bottom, those dots is the use of practice elements across sessions, and you can see how that corresponds. At the top, the graph is a monitoring treatment outcome using typically a standardized assessment measure. So this is one example of how evidence-based practices, I believe, can be better designed in a way that better matches how community practitioners are usually functioning, are usually trying to, and add some structure and some rigor to the way a lot of practitioners tend to pick and choose things that are going to be effective or that they believe are going to be effective for particular cases. The findings to date for modular psychotherapy are encouraging. There have only been a few studies so far, but those have demonstrated that modular therapies are more acceptable to providers than standard arranged evidence-based treatments. There's a lot of indication that they're more flexible, of course, than traditional manuals with regard to treatment timing and delivery, and that this can facilitate dissemination and implementation. And there's actually a recent randomized controlled trial that found that they were more effective both than standard arranged evidence-based treatment protocols and usual care. So we thought that this could be something, and we're not the only ones, but we did a pilot looking at the application of these kinds of models to school mental health. We actually used a version of the PracticeWise map system that I just showed you with a small number of school-based mental health practitioners locally. They selected 66 students for tracking, primarily with depression and anxiety. That was the way we sort of limited it to some of the most frequently occurring client presentations in their context. And they tracked those 66 students over a total of 487 sessions. And what was particularly noteworthy is that even though the average number of sessions per client was 7.5, the modal number of sessions was 3. And we asked them to select clients that they thought would actually come back a good number of times. And in a lot of ways, they were kids that came back more than a lot of other kids might have. But that's a particularly noteworthy finding for us that I'm going to be talking about as we move forward. But the findings of this really indicated that participating therapists were able to select appropriate students, they were able to track their use of modules, and they were able to administer standardized assessment measures. They were actually able to do so in 94% of their sessions. And that was actually a substantial sea change from usual practice. And this pilot was really the common ancestor for both of the projects that I'm going to be talking about. So one direction we've begun moving in response to this is toward a brief intervention model, something that's going to be 3 to 4 sessions, something that's going to really acknowledge that modal number of 3 sessions that we found in our pilot, and certainly consistent with some other research. There's a lot of reasons why there are so few service sessions delivered. Part of it has to do with client presentation, and some of them don't necessarily need more than that. We have 60% or so in one study we did that had subclinical presentations, at least in anxiety and depression. But these are large caseloads that these practitioners are dealing with. And I think this is a substantial natural constraint in the setting. Often these practitioners are the sole provider responsible for all the mental health care delivered in their school. There's frequent disruptions, as I've talked about, and engagement difficulties. And some clinicians did struggle to determine exactly which modules to select or which to prioritize. And all of this has really nudged us further and further toward this simplification, toward this enhanced learnability and enhanced kind of implementability through simplification. So that's what we're working on right now in our Brief Intervention for School Clinicians, or BRISC project. We're only in year 1 currently, but what we've laid out is this iterative development process, which is nicely facilitated by the IES Goal 2 grant mechanism. We're in study 1, and so far we've completed study 1 in year 1, and that's included conducting interviews and gathering qualitative data from local and national experts. And we also held a summit over the summer where we brought people together and gathered more information and more feedback on our model as it currently stands, and we're working to revise the protocol right now before we move on to some initial feasibility testing and then later some larger scale testing in the schools. I mean, even though the feasibility testing will be in the schools as well. The results of study 1, which were semi-structured interviews and then a nominal group process during our BRISC summit. And this nominal group process briefly just involves bringing together groups of people who, in this case, had reviewed our protocols and our sort of overarching theoretical model, and asking them to generate strengths and weaknesses and then particular action steps that capitalize on those strengths and address some of those weaknesses. So I'm going to be showing you just a subset of some of the information we got through these two processes. One of the directions for development that was identified, one of the suggestions, included underscoring the focus on improving both socio-emotional and academic outcomes. And I think this is really a great example of a natural constraint. And this is a great reminder of the kinds of natural constraints that we need to be aware of when working in schools. This quote, I think, sums it up fairly well. It's not compelling to say that simply reducing anxiety will lead to learning, although that's what a lot of our models say, and that's how we lay it out, because the kid is probably still not learning. The problem we have in mental health is that it's not its goal to improve learning, and mental health in schools thus has an added burden. So we're exploring ways to focus more deliberately through assessment of some school data and some school outcomes in the intervention that we're putting together. Additional findings included sort of a request for added guidance or protocol for how to refer out and how to collaborate with school staff, which is something that's also happening very frequently, and something that I think we'd be better suited to take on and incorporate into our model rather than trying to fight against. Additional clarity on how to select from among the limited number of modules, which I think is a great example of reduction of cognitive load. Staying small, keeping the focus on developing a targeted intervention within a tiered system. And this is a great example of functional minimalism, which we are often balancing against this feature creep or scope creep, and that these are sort of two sides of a similar discussion. There's the pull to be all things to all people, to gather information and to want to incorporate that, and at the same time to keep something that's going to be accessible and is going to be learnable and is going to be likely to be used. And then conducting a data inventory and making use of natural SPS data systems, Seattle Public Schools data systems, to the extent possible, which also ties into what I was just saying a moment ago about tracking some academic outcomes. So that's where we are with BRISC. Our plan is to, over the coming year, to develop a BRISC fidelity monitoring tool and to continue our iterative development with small-scale testing in schools. And through all of this, we'll be developing our training and consultation protocol in preparation for our Year 2 and Year 3 rollouts, which again is sort of a staged and iterative rollout with opportunities for revision along the way. So now I want to switch gears and talk about the other project that I've been working on. And this is one that's been funded by my NIMH Career Development Award. And we've also received some support through the Bill and Melinda Gates Foundation. I assume that most people are familiar or at least have heard of the work of Atul Gawande and the Checklist Manifesto, one of my favorite books. I've found this book to be, and this way of thinking to be very influential in a lot of what I've done. For those who don't know, Atul Gawande is a surgeon in Boston who's written a lot about simple things that we can do to reduce errors and increase sort of the quality of our services and increase outcomes. And what I've really taken away from this is the importance of emphasizing low-cost, high-yield practice changes and methods to support them. And I believe that standardized assessment is one of these. Standardized assessment is the use of measurement tools with empirical support for their reliability, validity, clinical utility. And there's evidence to suggest that these are important at various stages of treatment. Rating scales can increase the ease and accuracy of clinical diagnosis. We know that even though we're all trying our best, that we clinicians are not always particularly able to detect client deterioration or to predict who's going to drop out of treatment. And there's also growing evidence, both on the kid side of things and on the adult side of things, that administering standardized assessment measures and providing the results to clinicians can result in improved outcomes. So I think that the use of standardized assessment tools really provides an opportunity to enhance evidence-based practice learnability through the simplification and focus on just sort of one particular, we'll call it a component, we'll call standardized assessment a treatment element. And there's a lot of discussion these days, increasing discussion, about how dissemination and implementation can really be enhanced by focusing on these key competencies instead of the full treatment packages, instead of these poorly designed large-scale treatment packages, that we can take components and we'll be much more likely to be able to create large-scale change within a service system by rolling those out. And standardized assessment and progress monitoring really may be the low-hanging fruit of evidence-based practice implementation. Within schools, as I noted earlier, we found that there was good uptake of standardized assessment following training, and we found that pretty encouraging to carry forward. Unfortunately, in general, standardized assessment is not particularly common in mental health, and this is true regardless of what type of training background you're talking about. Within youth mental health, there was one study that indicated that only 40% of practitioners use parent rating scales, and that 29% use child or self-report rating scales, and this may even be an overestimate. When provided with scored assessment profiles, there's actually another interesting study that indicated that even when a practitioner was handed scored assessment profiles, a lot of them struggled to actually integrate that into their treatment planning, into their progress monitoring over time. And it's more difficult than it sounds. Just getting that information source is one step along the way. But what we've found, and what we've talked with a lot of our practitioners about a lot, is that use of standardized assessment tools can break down at all sorts of stages along this process. You might select it and administer it and score it, but then it just kind of sits there and you don't do any real interpretation. Or even if you do, the likelihood that you might provide feedback to clients is probably even lower, let alone using it for ongoing treatment planning. So there's a lot of different steps along the way that one needs to successfully navigate to really make good use of standardized assessments. What we found in surveys of some of our local school-based health center practitioners are that we are consistent with that relatively low amount of use. What we asked them was for what % of their caseload they had done these various things related to standardized assessment. The first two are within the last month, and the bottom 5 are within the last week. And you see that almost all responses are clustered near the bottom. This is percentage of clinicians that gave that percentage response. So you see that they were doing, there was some variability on giving a standardized assessment measure at the initial couple meetings at intake, but that most of these other practices fell off over time. Not many giving them to teachers, not many changing treatment plans based on standardized assessment data. We don't know necessarily what the optimal percentages are for some of these things. You obviously don't want to change your treatment plan every single week. If you're doing that, there's probably larger problems. But I think this is still an indication that the use of standardized assessment tools could be greatly improved. So a lot of the work that I've been doing has been lately centered around how to support the use of standardized assessment tools and for progress monitoring, initial assessment and progress monitoring. Measurement feedback systems, which provide computerized infrastructure to support assessment and monitoring of intervention targets, and in addition to that, can also be tools to support communication among providers about treatment progress for the purposes of consultation or supervision. I think have a lot of promise to increase the use of standardized assessment. They haven't really been utilized in school mental health, but that's what we're working on. We're working to adapt this measurement feedback system, the mental health integrated tracking system that Jürgen Unzer has used in some of his work and some work that I know a lot of you have been involved in to support collaborative care for adult depression. And what we're doing now If you haven't seen it before, this is the MHIT system. We're working to adapt this for use by practitioners in schools. We're working on identifying and have largely identified some assessment measures that are going to be appropriate for kids, and have gone through a number of iterations already and are going to continue that process to get feedback on the usability and the appropriateness of the MHIT system for use by school-based mental health practitioners. So our recent efforts in this process have included focus groups to evaluate kind of basic things like provider workflow and usability of these different measurement feedback system components. We've done some piloting and feedback with the unadapted system in order to get sort of initial impressions and identify sort of strengths and weaknesses that we can address in our next iteration, which we're working on rolling out pretty soon. A lot of this information has been fed back into a year-long stakeholder committee that we held last year and that recently wrapped up at the end of the summer. In order to make decisions about how to create something that's going to be most appropriate for the context. It's going to incorporate all sorts of natural constraints, because it's really a process first of identifying those constraints and then figuring out what to do about them and how to make use of them. And we had a great collection of local stakeholders, practitioners and administrators, people who represented the schools, as well as people who represented a lot of the service organizations. These are just some brief survey results we got from the, kind of as a baseline about the unadapted version of MHITs. These are essentially satisfaction ratings. And you'll see that they were mid-range, that one of the lowest was actually intuitive appeal, and I think we'll want to look at that over time. But that these represent, I think, generally encouraging levels of satisfaction, but something that we're going to want to continue to look at over time and see if our adapted version, when we roll it out, can really move these up a bit and create something that's going to be compelling and going to be appropriate. Our next steps for measurement feedback system development include, in December, conducting some usability testing of the adapted system with a small number of practitioners. And then in the winter and spring, we're going to be rolling it out with a randomized subsample of our school-based health center practitioners to test the impact both on clinician behavior and on student outcomes. Student outcomes being academic outcomes, mental health outcomes, and also things like therapeutic alliance. In the 2013 and 2014 academic year, our plan is to move toward full system rollout, and then in the context of that, to evaluate the added benefit of auto-populating academic data. This is a natural constraint that I hinted at a number of times throughout the presentation, but I think that if we're going to have something that's going to be effective and compelling ultimately in the school context, we need to be evaluating these kinds of functional outcomes that are at least as important, if not of greater importance, than mental health outcomes to the providers working in that setting. Is the kid getting to school? These are already things that they try to incorporate, not necessarily in a routine or systematic way, but that they try to incorporate and try to address in the services they provide. But we're trying to create a tool that's going to really allow them to do that in a way that's seamless, in a way that's going to reduce their effort and cognitive load, and hopefully improve the outcomes for kids. So we'll be randomizing youth within the system to either MHITs or MHITs plus academic data to see both the impact of having those data on the services delivered and on the impressions by users of the system, the school-based clinicians, their impressions about the usability and effectiveness of that system. So the last thing I just want to leave you with is that sometimes having the file, having the pocket knife, having that little pair of scissors, even though it doesn't cut everything, and maybe having the tweezers beats a backpack full of tools. And I think we've got time for some questions or discussion. Thanks.
I have a question.
Yeah.
It seems like engineering, like you're taking the course in engineering, so it's fantastic, but it seems like engineering would be the kind of the theoretical perspective that would help you go from complex knife to simple knife. I mean, can you say more about like what specific engineering principles, or there are ways engineering principles interface with psychological principles or theories that are getting you there?
You might want to repeat the question
Yeah.
to the people.
Yeah, could you?
So the basic question
Yeah.
is, it seems like if you are, getting your K awards allowing you to kind of think so if we are sort of using like lean manufacturing principles would be exactly what would take you from complex knife to simple knife. But how, what's the process? How does engineering help with that, or not?
Or how does design help with that?
Design, yeah. I mean,
So the question is sort of how does design and how do design principles help you get from the backpack knife to the pocket knife you can put on your keychain, and how do you go through sort of the pruning? I would say part of it is through multiple iterations and figuring out exactly what you have to have and what sorts of things are going to be unnecessary, and sort of coming in with the mindset that many things are likely to be unnecessary, and I would say in a lot of ways that the burden of proof is on, potentially, if you want to come in with that mindset, on making them necessary rather than irrelevant, and rather than just noise around sort of what you're trying to zero in on for the purposes of parsimony. And I'd also like to add, it was really fascinating being enrolled in these classes in the certificate program, because I came in thinking that it was only going to be relevant to the adaptation of health information technologies, and I do think that it's just that some of these principles and this way of thinking and some of these methodologies, many of which are qualitative in nature, has just broad applicability to a lot of the things that we spend a lot of time thinking about.
Governmental agencies, insurance companies, payers are enthused about evidence-based practice, and yet aren't doing what you're talking about. This thing doesn't really work. They're just doing it because it sounds good and because they think they're going to save money.
Right.
Is there any effort for them to start doing it smarter?
So the question is whether there is any effort that I'm aware of within sort of policy and sort of larger scale administrative decisions to do things in a more sort of streamlined or well-designed way rather than just kind of jumping on the traditional evidence-based treatment bandwagon. I would say not necessarily. I think it depends on where you are and what policymakers you're talking about. I think it's a long process to sort of wean people away from the evidence-based treatment protocol approach and way of thinking that we've spent so long convincing people is the end-all, be-all of mental health care. So I think that there are sort of pockets of understanding of how things can be better designed, even if they may deviate from sort of the more traditional models of particular intervention protocol with particular set of fidelity tools that must be used in order to demonstrate that you're doing that particular protocol. But I would say that there's a ways to go.
I would suggest one starting point might be our medical school and possibly medical school administration. I think they should really hear your talk.
Well, they're welcome to come knocking.
So Sharon asked me to help close things up here, so I want to thank Aaron for a wonderful and stimulating presentation, and we look forward to having you come back and tell us the outcome. So thank you so much.
Thanks.